Welcome back to Med News FM. We just explored the latest updates in genome sequencing, and now continuing with this theme, we have a special presentation on the fascinating genetic condition called Duchenne muscular dystrophy. Let's kick it over to the Med reporters in the studio. Ladies, what do we know about this disease?
Good morning, Bay Area. I'm Lily.
I'm Allie.
And I'm Olivia. We're here to talk to you today about the genetic condition Duchenne muscular dystrophy, or DMD.
DMD is one type of muscular dystrophy and is a recessive sex-linked genetic condition that leads to progressive muscle weakness and wasting. The DMD gene is part of the X chromosome. A recessive mutation causes DMD. Males are more often impacted because males receive one X chromosome and one gene. If the gene is a recessive mutation, they will have DMD.
Female carriers may not show symptoms, but there's a 50% chance of passing the mutation to their children. A minority of females with one mutation, called manifesting carriers, show some symptoms of DMD, although often much less severe than a DMD-diagnosed patient.
The sudden appearance of DMD in a family can happen in one or two ways. First, the genetic mutation affecting the dystrophin gene may have been slightly passed down through female carriers for generations without prior knowledge. Second, DMD can result from a spontaneous mutation, a new genetic change occurring in the mother's egg cell. Since this mutation is not present in the mother's blood, standard carrier testing would not detect it, making the diagnosis unexpected.
The dystrophin gene is the largest gene that has been identified in humans so far, containing 79 exons, which each range from 10 to 300 nucleotides long and spans 0.1% of the X chromosome. 2/3 of the mutations that occur in this gene are deletions that span from one to multiple exons, and the mutations in this gene cause DMD because the mutated gene fails to produce enough functional dystrophin.
Some individuals have Becker's muscular dystrophy, a less severe form of DMD when functional dystrophin production is only moderately reduced rather than eliminated, and muscles do not degenerate as quickly as in DMD.
DMD is caused by a lack of protein, dystrophin. So, what exactly is dystrophin? Dystrophin is a rod-shaped protein that links the cytoskeleton network within muscle cells to the transmembrane parts of the dystrophin glycoprotein complex. Dystrophin plays a central role in keeping muscle cells stable and preventing damage during muscle contraction. Muscles contract during any type of muscle use, such as walking, breathing, running, or lifting weights. When there's a lack of dystrophin protein or the protein is incorrectly shaped, the structure of the muscle cells weakened, ultimately leading to muscle decay.
Let's get into detection. As early as 2 years old, parents may notice enlarged calf muscles or pseudohypertrophy. As children enter preschool, the patient will have trouble climbing stairs, getting up from the floor, running, and often using their hands to push themselves upright.
The average age of detection is 4 years old. As muscle decay continues, patients struggle to walk and visibly stick out their stomachs and pull back their shoulders to keep balance. By age 12, most children will need a wheelchair. DMD can also cause cardiomyopathy, or heart muscle disease, which decreases the heart's ability to pump blood efficiently.
If a patient shows signs of cardiomyopathy or other symptoms of Duchenne muscular dystrophy, a doctor will first review the patient's family and medical history and may conduct genetic testing. A creatine kinase blood test can help detect muscle damage by measuring CK enzyme levels, which leak out of damaged muscle cells. Elevated CK levels indicate muscle breakdown and confirm that the weakness originates from the muscles rather than the nerves. However, this test does not specifically diagnose DMD, as other muscle disorders such as Becker's muscular dystrophy and muscle trauma can also cause elevated CK levels.
Muscle biopsy, taking a small sample of muscle tissue from a patient, can identify if a patient has muscular dystrophy by looking for abnormal levels of dystrophin in the muscle. An ECG, or heart rhythm test, assesses whether the heart muscle is weakened due to DMD.
And my very first patient out of graduate school came in as a 4-year-old boy who was walking on his toes. It was called idiopathic toe walking, which just means that he's walking on his toes and nobody can figure out why. And that was my very first patient as a licensed physical therapist, and I was young and scared of everything and trying to figure it all out. But it turns out that he had Duchenne. And so So that family ended up founding the nonprofit that I work for called Cure Duchenne. All my patients have either Duchenne or Becker muscular dystrophy. Seeing many of my patients walking until they're teenagers is a huge success story, because before they weren't even supposed to live that long. And now we don't, not just are they living much longer, like they're walking a lot longer before they actually lose. So we've like extended all of those things that people told us is impossible. There's a lot of victories right now in the science part of Duchenne as well. So we have lots of hope. There's lots of new medications that are either on the horizon or currently FDA approved. And that's like a huge moment of victory too, because 20 years ago when I started this, there was nothing. There was like no drugs, nothing like that. The typical age of diagnosis is right around that 4 or 5 years old, because that's when the differences of what they're doing really start to show. And that's when doctors start getting involved and realizing that there's something going on. And so we start making adaptations like, oh, instead of PE, they're going to do this. Instead of running at recess, they're going to play with Legos. You know, we start making changes. They start showing their weakness a lot more around the age of 8, 9, 10. And you can really see the difference in how they walk and how they move. And that's when we start to make sure that they have some sort of, we call it powered mobility device, like a powered chair or a mobility scooter or something like that. And that's when their routine really starts to look a lot different to people.
Thank you, Ms. Wallace, for that amazing insight. There is no cure for DMD, and not too long ago, boys with DMD did not usually survive past their teen years. New advances have improved life expectancy, and living into the early 30s is becoming more and more common. About 20,000 children are diagnosed with Duchenne's globally each year. Treating DMD focuses on slowing disease progression and managing symptoms. The most common treatment is the use of corticosteroids, or steroid supplements. These are synthetically made drugs similar to cortisol that slow the effects of DMD on muscles and reduce complications, like scoliosis and loss of ambulation. And these are most effective if started early, prior to muscle damage. Corticosteroids are anti-inflammatories. They work by reducing inflammation, by slowing the pace of muscle damage, stimulating repair, and maintaining muscle cell membrane stability. They bind to receptors within muscle cells, which suppress genes that synthesize multiple inflammatory proteins.
Gene therapy for DMD is typical because the dystrophin gene is currently too large for scientists to deliver using current gene therapy methods. There have recently been exon-skipping gene therapy drugs to create a shorter version of the dystrophin gene, which reduces the atrophy of the muscles. These encourage the cell to skip over certain mutated exons. Small sections of DNA, antisense oligonucleotides, are used to mask the exons that should be skipped, and then these exons are ignored during protein production, creating a shorter but functional form of dystrophin during synthesis. This manufactured, smaller form of the protein, called microdystrophin, helps restore some muscle function. However, this truncated protein does not function at the level of normal dystrophin. It needs to be expressed at several times the level of the normal protein.
Physical therapy can minimize the impacts of DMD. Regular stretching mitigates contractures, lasting tightening of muscles, tendons, or ligaments by keeping them loose. Keeping the body as flexible, upright, and mobile as possible safely in a monitored space is vital in maximizing mobility yet not causing harm. Assisted ventilation may become necessary as the muscles for breathing become weaker. Mobility aids such as braces can be required to support limbs as muscle function deteriorates. Regular cardiac monitoring to best deter heart muscle decline is vital, as the heart is a crucial organ that is impacted by DMD. Some side effects like scoliosis and contractures demand preventable surgeries at some point in an individual's life.
In recent years, scientists have made large strides in increasing the lifespan of those with DMD and creating a more comfortable and manageable life for these patients.
Hopefully, we will see a possible cure arise in the near future.
Thanks for tuning in.
Thank you, medical reporters Lily, Allie, and Olivia, for educating us on Duchenne muscular dystrophy. After the break, join us as we delve into the newest updates on the norovirus outbreak here on Med News FM 11 o'clock news. I'm told it's a real stomach-turning event.